I want to thank Tony and Beth and Bob for organizing this conference. Uh, After I did my postdoctoral fellowship at the NIH, uh, where I lucked out and applied to be anywhere just so I didn't have to go to Vietnam, I ended up as Bob Wurtz's first postdoc. He too um, was at, um, had a relatively limited number of people that he could choose from because he hadn't published at that time his transformative paper on the awake monkey. So it was a random event. And then after my postdoc with Bob, I decided to go back and do a neurology residency, so, something that Bob thought was foolish. And then came back to Bethesda and decided I really liked being a doctor, not as much as I liked actually doing science. And so ever since that time, I've always done a little bit of clinical neurology, first at Georgetown, and then in New York at Columbia Presbyterian Medical Center, where I do neurology that is entirely, with one minor exception, unrelated to my research. So I'm a member of the neurohospitalist team and go in and take care of clinical patients, do consults, mostly teach residents. And given a certain amount of attention deficit disorder, it helped keeping abreast of two fields is a solution to that. Okay, so medical diseases like failure of kidney, heart, liver, have a number of treatment modalities, drugs, surgery, and when all else fails, as a last resort, misspelled, organ transplant, even for traumatically destroyed faces. But you can't translate the brain or even the spinal cord. And so the solutions to neurologic diseases that have reached the end of the string are different. So diseases that destroy brain, spinal cord, peripheral nerve, and muscle require different solutions. And so I'm talking about Parkinson's disease, amyotrophic lateral sclerosis, spinal cord transection, peripheral neuropathy, not a motor disease, but I'll show you that it can be considered that, and stroke. So Parkinson's disease. Dr. Vitek is going to describe how Malin DeLong's search for the basal ganglia's contribution to the generation of movement led to deep brain stimulation of the subthalamic nucleus when L-DOPA can no longer manage the symptoms. And that's the great poster child for monkey research, because it says that answering a basic question, I wonder how the brain drives movement, ends up in helping treat a disease. Now, DBS improves the classic symptoms of Parkinson's, rigidity, tremor, bradykinesia, but not the non-motor symptoms, apathy, sleep disorders, impulse control disorders. So even for the poster child, there's more work to be done. And basic science studies in the monkey will have to unravel this failure of DBS. Now consider amyotrophic lateral sclerosis. It destroys motor neurons and motor cortex. It's called Lou Gehrig's disease because it killed the famous Columbia and New York Yankee baseball player, Lou Gehrig. And there's currently no real understanding of the mechanism, aside from a few rare hereditary diseases, for example, superoxide dismutase deficiency. But most ALS patients have normal SD. This incurable disease presents a terrible ethical problem. Patients with ALS die of respiratory distress or starvation. They can't breathe and they can't cough or swallow effectively. So food can travel from their mouth into their trachea, leading to repetitive bouts of pneumonia. Respiratory distress can be treated with tracheotomy to protect their airways and enable artificial respiration, and a percutaneous gastrostomy, a PEG, can insert a feeding tube through which nutrients can be distilled into the intestinal system, so it can keep them alive, breathing, eating. And many patients reject this option, preferring to die, like my last ALS patient on the ward who died while I was covering the Columbia ward service, voluntarily making the choice against a trach and a peg. Some of you may have known Wayne Wickelman. He was a great mathematical psychologist. He was married to Norma Graham, a member of the National Academy, one of the great visual psychophysicists. Wayne developed ALS and chose to live in his living room on a respirator with a trach and a peg. For most of that time, he was able to communicate with lip and eye movements. His wife and children could understand him. New York had a day's blackout, but Wayne's respirator batteries lasted. Ultimately, the process of ALS invaded much more of his brain, and he died. He lived for 5 years with a trach and a peg. Many of those years were good. He and his daughter Ingrid wrote a book together, Math Coach, about teaching your child math. It's still available on Amazon. So how can primate research help a patient with ALS? A prosthetic arm could help him to do some of the activities of daily living. As you're going to hear from Richard Anderson and Andy Schwartz, because of what we know from monkey research, the idea of a prosthetic arm has moved from a dream to an engineering problem. Talking with a trach and a paralyzed larynx is impossible. A language prosthesis is a dream. Could signals in Broca's area activate a speech synthesizer? Monkeys have stereotyped calls. The leopard call tells other monkeys to climb higher in the trees. The eagle call tells them to get out of the trees. Could the network that drives the monkey's call drive a monkey's speech synthesizer as a model for helping Wayne to talk? And how far would that be from decoding Broca's area? And if our cell and molecular biologist colleagues come up with a model of ALS, a treatment may result, and that treatment will have to be demonstrated first in monkeys. Spinal cord injury. Christopher Reeve fell off a horse and broke his neck, severing his cervical cord. He could shrug his shoulders, but not much else. Car crashes, athletic injuries, bicycle accidents, transverse myelitis, and neuroimmunological disease fill the wards with quadriplegics. Acutely, spinal cord damage affects not only limb movement and posture, but bladder, bowel, sexual function, and sensation. The greatest therapeutic advance in my lifetime was the discovery that after the spinal shock of the accident goes away, the urinary sphincters could be trained to hold urine in the bladder, and until the bladder was externally stimulated. This enabled rehabilitation centers to eliminate indwelling catheters, eliminating chronic urinary tract infections, and subsequent amyloid-induced renal failure. And so that's the level of 20th century research for spinal cord injury. Now, there's a central pattern generator in the spinal cord. Newborn babies show walking movements. This central pattern generator is used when we walk, and the lumbar CPG could be triggered to drive a robotic exoskeleton. But growing back some spinal cord to bridge the injury would be better. Growing back a several spinal cord is a basic molecular and cell biological problem. And because mice aren't primates, much of this basic work will have to be done in monkeys. And certainly the treatments arising from that work will have to be developed in monkeys. Think about sensory neuropathy. Pain is unpleasant, but it protects us against injury. There are a number of different types of sensory nerve fibers carrying different signals, from vibration and pressure to pain. Patients with small unmyelinated fiber peripheral neuropathy, most dramatically congenital absence of pain, but also patients with types of diabetic, toxic, and infectious neuropathies, for example, leprosy, can't feel pain. So injure themselves by not being able to activate pain-induced withdrawal circuits. Thermosensors could be used to stimulate spinal and central pain withdrawal circuits, but for this to be realized, we'll have to know much more about the spinal, brainstem, thalamic, and cortical processing of pain in monkeys. So, stroke and plasticity. Stroke results from the occlusion of a cerebral artery. The deficit from the stroke depends upon the tissue destroyed. The classic left middle cerebral artery occlusion affects motor control and speech. This is an MRI, T1 MRI of a recent stroke. And the best way now to treat stroke is to prevent it. Treat hypertension, diabetes, lower cholesterol. Carotid endarterectomy after a transient ischemic attack, a mini stroke that gets entirely better, can prevent the occurrence of a big stroke. But once a stroke occurs, you have 3 or maybe 4.5 hours to melt the clot away, infusing tissue plasminogen activator, TPA. Within the time limit, you need a CT scan to show that it's an infarct and not a hemorrhage, repeat neurologic exams to demonstrate the stroke is not getting much better all by itself, and you have to control blood pressure. If the patient meets the criteria, you can give TPA and cross your fingers, and if TPA doesn't work, sometimes drilling out the clot with a catheter does, but often TPA and clot busting don't work. So a mystery is, why do some patients improve in the months after a stroke and others with a similar lesion never get better? To understand this, we need a good primate stroke model that reproduces the spectrum of recovery. Basic research into neuroplasticity and reorganization of networks has the potential ultimately to facilitate stroke recovery. And a hint of the nature of the problem is that the limbic system, rather than the sensory motor system, may be the key to recovery from stroke. A study from John Krakauer and Randy Marshall using post-stroke MRI. And if it's the limbic system, does that recovery from stroke involve motivation? So motivation and constraints therapy has become an interesting issue. So Charles Sherrington showed that a monkey with dorsal rhizotomies didn't use the diaphragm arm, even though his motor system was intact. And so he would look like somebody who needed an improvement in motor function. Ed Taub showed that monkeys with bilateral intrauterine dorsal rhizotomies used both arms reasonably well. But monkeys with unilateral dorsal rhizotomies, who could only feel in one arm, only used the diaphragmated arm when the arm with an intact sensory system was constrained, forcing them to use the arm. Constraint therapy is now a useful rehabilitative tool, forcing patients to use the weakened limb and recover its function. And so understanding how motivation drives recovery from neurologic injury will enable the development of more effective methods for stroke and other kinds of rehabilitation. And this too will require monkey research. And this is Ed Taub, a cautionary tale. Ed's lab was closed because of PETA. In 1980, Alex Pacheco, a young man who had founded in somebody's garage a organization for people for the ethical treatment of animals, volunteered to work in the Taub lab. Ed Taub went on a week's vacation. When Dr. Taub was on vacation, Pacheco let the husbandry in the lab become neglected and took inflammatory pictures that were published in the Washington Post. Pacheco then reported Taub for violations of animal cruelty laws based on the monkeys' living conditions that he had made worse. Police raided the lab, seized the monkeys, charged Dr. Taub with 119 counts of animal cruelty and failure to provide adequate veterinary care. The first such charges to be brought in the United States against a research scientist. The NIH stopped his grants without due process. So there's a public battle. Ironically, Ed Taub's research led to 2 important therapeutic advances. The idea of increasing motivation by constraining the good limb has become a useful technique in stroke rehabilitation. The technique of fetal surgery has led to the successful treatment of myelomeningocele and pulmonary malformations in human fetuses. And we must bring the battle to preserve basic neuroscience in monkeys to the public, as Larry said, or we will all end up as Ed Taub's great science, no labs. Thank you.